So thank you very much, Berit, and good evening to one and all. So the challenges that we encounter in the diagnosis of childhood tuberculosis arise from a varied clinical symptomatology, the difficulty in the collection of specimen, and low yield from diagnostic and laboratory parameters. I have nothing to disclose, and the objectives for tonight's lecture are to discuss the diagnosis of TB, the common diagnostic tests used in TB, and the common chest X-ray findings seen in tuberculosis. Okay? So let us immediately go and proceed to our first question for the night. Okay, so in the new TB guideline, what initial diagnostic tests should we request for sputum and gastric aspirate? We're going to give you 5 seconds to answer, okay? And the choices are A, sputum microscopy for acid-fast bacilli, B, gene expert for Mycobacterium tuberculosis with rifampicin resistant test. The new, letter C, the new TB loop isometric amplification test, or letter D, the gold standard, which is the TB culture and sensitivity. So the timer starts now. 5, 4, 3, 2, 1. So let us look at the poll. Do we have it already? So there you go. Oh, most still think that it's sputum microscopy. Okay, let us see. Okay, and some say it's gene expert. Okay, so we'll know the answer as we go through with the lecture. Okay, so can you stop the poll, please? Okay, okay. So again, our patient presented with 3 months history of fever. And in the diagnosis of TB in adults and adolescents who are more than 15 years of age, they may be considered as having presumptive tuberculosis if they have the following signs and symptoms that last for 2 weeks or more. So either cough, unexplained fever, or unexplained weight loss and night sweats. Okay, if they have at least one of these signs and symptoms, then you can consider them as having presumptive tuberculosis. If none, then you can request for a chest X-ray because there's actually a DOH promotion where they are advocating aggressive TB case finding in adults which they refer to as your chest X-ray for all adults. So you can actually request for your chest X-ray. If your chest X-ray is suggestive of tuberculosis, then also you can consider this patient as having presumptive TB. So next, what will you do now? You collect your sputum examination sample and then submit for gene expert, your PCR-based gene expert determination for the presence of Mycobacterium tuberculosis and test for rifampicin resistant. Only if your gene expert is not available, then you can send your samples for smear microscopy or for TB lamp. Actually, there are already available gene experts in almost all of the regions, so you can submit them to your TB-DOTS units. So what about children for less than 15 years old? A child with at least one of the following signs and symptoms that last for more than 2 weeks may be categorized as having presumptive TB also. What are the symptoms? Cough and or wheezing that does not go away despite treatment with antibiotics or your bronchodilators. Or fever that does not go away and you were not able to diagnose even after ruling out other causes of your fever. Or weight loss or failure to thrive that lasts for more than 2 weeks that cannot be explained and does not improve with nutritional management. Okay. This will be with or without the risk factors that predispose to a higher chance of acquiring TB infection or having a more severe course of illness, such as your age of less than 5 years old, your presence of HIV, severe malnutrition, measles, or use of immunosuppressive drugs. Okay. There's actually a caveat here that says that among pediatric patients who have TB contacts, okay, even if you don't have the above signs and symptoms, but the presence of decreased activity, decreased playfulness, and poor appetite that lasts for 2 weeks, then you can consider them as having presumptive tuberculosis also. Or if they come to your clinic with chest x-rays that are suggestive of tuberculosis, okay? So what will you do then? Okay, so you collect also your sputum, okay, for children less than more than 8 years old if they are able to expectorate, and submit them for expert study. If you are not able to collect your sputum, then what do? You do your chest x-ray, okay, to determine whether there is chest x-ray findings of tuberculosis, okay. So for children or adults who have extrapulmonary tuberculosis, then you can also collect your samples, either pus cells, any tissue samples or fluids, and also submit them for expert study. Okay. The next question. So how many sputum samples should be submitted for expert TB? Okay. The choices are letter A, 1, letter B, 2 samples 1 hour apart, letter C, 2 samples 1 day apart, or letter D, 3 samples for 3 consecutive days. Okay, so the timer starts now. 5, 4, 3, 2, 1. Okay, let us see the results. And, oh, magkakaiba po. But mostly, pinakamadami is letter D, 3 samples for 3 consecutive days. Okay, let us see. Can you please, okay. Actually, that was the old, right? When you collect your smears, you do it for 3 consecutive days. Okay. But now, hindi na po. I still get calls asking how should we collect our sputum or your gastric aspirate. So let's go through them briefly. Okay, so for sputum collection, proceed to your collection area, gargle, and then make sure that you thoroughly wash your mouth. Take a deep breath and then exhale. Do this 3 times, 3 beses. But on the 3rd exhalation, you cough out forcefully so as to produce a sputum sample that you will put in your specimen bottle. However, in our present COVID setup, spot sputum test is not already done. You don't go to your TB dots and do your sputum collection there. What you do is you submit your specimens to your TB dot units. Okay, we still get samples. However, if this patient is positive for COVID, or the patient has not been tested for COVID, make sure that you seal the specimen of that patient and then put them in a Ziploc and then on a tackle box and then label them properly for the protection of our medical technologies. So, pwede pa rin pong mag-submit ng specimens. Okay? So, for Gene Expert, the minimum amount that you should collect is 1 ml. Others would say 1 teaspoon, at least 1 teaspoon. And you can collect only 1 on any collected spot sputum sample. So, isa lang po for Gene Expert kasi PCR siya. Okay? But if Gene Expert or your TB lump are not available and you have to submit for smear microscopy, you have to collect at least 3 to 5 ml and submit 2 samples. The second sample should be collected 1 hour after the first, or you can submit it the next day, an early morning sample the following day. What about gastric aspirates? Remember that we don't usually collect for gastric aspirates. It's not routinely done, and it's only done if it's really actually needed and there is difficulty in arriving at a diagnosis. And if done, it's best done in a hospital setting. And it should be collected in the morning before the patient gets up from the bed, okay? With fasting of at least 4 hours or 3 hours for infants, okay? So, gently insert your NGT and then withdraw at least 2 to 5 ml of your gastric fluid. If you are not able to withdraw fluid, then you can instill 5 ml or 5 to 10 ml of sterile water or plain NSS and then try again to aspirate. Okay, you can repeat this for a maximum of 3 times. Okay, and then at least collect 5 to 10 ml before submitting your specimen. So there's actually a study that was done in 2015 by Dizon et al. It's a meta-analysis of 15 studies, including almost 5,000 respiratory specimens that compared their expert with your culture. We know that your TB culture is the gold standard, but the yield is still only about 20 to 70%. Okay, so compared with your culture, the expectorated or induced specimen samples and gastric lavage gives you a sensitivity of 62% and 66% respectively with regards to your TB expert test. Okay, and you can see here that the sensitivity of Gene Expert was 36 to 44% higher than the sensitivity of your microscopy. So it's still a lot better than your acid-fast stain. Okay, so let us go back to our algorithm for children less than 16 years old. So if you detect Mycobacterium tuberculosis in your Gene Expert, you treat this patient as bacteriologically diagnosed TB. And these are examples of your request form and result form. The one here on the right is an actual result form, and it will state there MTB detected or not detected, and rifampicin resistance detected or not detected. Okay. If, for example, you are not able to detect Mycobacterium tuberculosis, but you still have the signs and symptoms, then you do your chest X-ray if it has not been done yet. Okay, and if your chest X-ray is strongly suggestive of tuberculosis, then you may consider treating this patient as a clinically diagnosed TB. Okay, but if the chest X-ray comes out as normal or you are not sure, then you may do a trial of antibiotics and or observe the patient for 2 weeks. If the symptoms are still persistent after 2 weeks, look at the contact of this patient. If the patient has a contact of active TB case, then you may treat this patient. It's your prerogative to treat this patient as a clinical diagnosed TB. If there is no contact, what should you do? You do a tuberculin skin test. Okay, so man-to test tayo. And if the TST is positive, then see if you really need also to treat this patient as clinically diagnosed TB. However, if the TST is negative, then you might want to refer this patient to a specialist already. Okay, so this table just summarizes the classification of TB depending on how you want to report it. So here, depending on the bacteriologic presence of TB, again, bacteriologic confirmed if it's TB positive at expert TB, AFS positive, TB lump, or TB culture, and clinically diagnosed if it's negative with the above. However, the patient has clinical signs and symptoms, chest X-ray, or other imaging studies, histology, and biochemistry findings that are strongly suggestive of tuberculosis. And you say that this patient has pulmonary TB if there is involvement of the lungs with or without extrapulmonary involvement. If it's only extrapulmonary involvement without involvement of the lungs, then you can label this as extrapulmonary TB. If the patient has never been treated for TB or has already only less than 1 month of TB treatment, then consider this patient as a new TB case. However, if there is already a previous TB treatment or there has been treatment for more than 1 month, regardless of the TB completion, then consider this patient as under the retreatment category. So with regards to resistance, drug sensitive, if there is no resistance to any anti-TB medication, isoniazid resistant TB, rifampicin resistant TB, or MDR resistant if resistant to both isoniazid and rifampicin, and then pre-XDR TB if resistant to both plus either a fluoroquinolone or your second-line injectable anti-TB drugs like your amikacin, kanamycin, and your capreomycin, and XDR-TB if resistant to all of those mentioned. Okay, so the last question for this segment, TB can present on chest X-ray as any of the following. Letter A, hilar adenopathy. Letter B, atelectasis. Letter C, consolidation. Letter D, A and B only, and letter E, all of the above. So 5 seconds. Okay, so 5, 4, 3, 2, 1. Okay, let us see. Okay, all of the above. Very good. Correct po tayong lahat. Okay, so we now look at some of the common chest x-ray findings that we see in tuberculosis. Okay, the first three ones are the ones that we see more in childhood tuberculosis, and the other two are more common in adult type TB. Okay, so this first slide, chest x-ray shows you hilar adenopathy. And it results from the drainage of tubercle bacilli through the lymphatics from a lung focus. The presence of these three, a gone focus, that's your number one, your lymphangitis, that's your number two, and your hilar adenopathy, the number three, is what we call as primary complex. And you only label this X-ray as primary complex if these three are present. Okay. This large lymph node can even compress your airways, such as your bronchus, and the most that will lead to your atelectasis. And the most common site is actually your right middle lobe, which you can see here better on your lateral view as a wedge-shaped triangular opacity. There it is, wedge-shaped triangular opacity on the area of your right middle lobe. Okay. TB can also present as chronic pneumonia or TB consolidation that does not respond to your antibiotic treatment. Also, it may present as a miliary pattern. This one, there is a hematogenous spread of your tubercle bacilli that may lead to your miliary TB, which is seen on chest x-ray as your small granulomas or foci that look like their millet seeds throughout the lung parenchyma. Okay. TB lesions can also be seen as fibrotic lesions on your chest x-ray, or in more advanced cases, as cavitary lesions secondary to the destruction of your lung parenchyma from your caseous necrosis, or as pleural TB resulting from contiguous spread of your subpleural foci, or a lymphatic or hematogenous spread causing the accumulation of pleural fluid. Now, most radiologic lesions actually resolve. Some may lead to minimal sequelae like your fibrosis, but a few may progress to more severe lung findings such as your bronchiectasis, which is the destruction and dilatation of your airways that result to chronic suppurative lung disease and is characterized by copious sputum production, recurrent wheezing, and recurrent infection. So, lastly, let me just show you the approximate timetable for the progression of tuberculosis in the young. Okay, so usually TB meningitis may ensue 2 to 6 months after TB infection. Your pleuritis may come after 3 to 9 months. Your scrophulodderma after 3 to 9 months, or even up to 12 months, and then involvement of the bones and joints may occur after 1 to 3 years, and then renal TB after 5 to 25 years. So this is my last slide. Kamsahamnida, and these are my references. And we now proceed to the meat of tonight's discussion by Dr. Trajano, our TB meningitis. Thank you.